This is Blood and Cancer, the official podcast of MDH Hematology Oncology. I am the voice of MDH Podcasts, Nick Andrews.
This week on Clinical Correlation, on delivering good news.
And I'm joined this week, as I always am, by the editor-in-chief of MDH Hematology Oncology and the voice of this podcast, Dr. David Henry. This is the 61st edition of Blood and Cancer. Dr. Henry, how are you?
I'm fine. Nick, how you doing?
Doing well. Obviously, some rumors here and there over the past few weeks as we record this in 2020 that March Madness would be canceled. It has not been canceled. There will be plenty of basketball to watch on TV as we move forward. Whether or not there will be fans, we'll see.
Audience.
Yes, which is fine with me. I have watched every March Madness game I've ever seen from the same seat in the house, and that's the seat in my house.
Right. Well, of course, as we go to press and air this episode, there's a lot of concern nationally. It's moved from the West Coast to the East Coast. I'm in Philadelphia, and so many cancellations and concerns and information and a little misinformation in the lay press. But I think the medical system is keeping us aware of what we know and don't know, and knowledge is power, so hopefully that continues.
Absolutely. And of course, in one of our sister shows, Dermatology Weekly, we reported this week that the AAD, the American Academy of Dermatology, decided early in the wee hours of the morning on Tuesday, March 9th, to cancel the AAD meeting in Denver. And if you are thinking of attending a medical meeting in the next 6 weeks, whether or not that meeting will be canceled, all of that information is available at mdh.com. And in various specialties, something that we mentioned last episode, and we wanted to keep everyone up to date as there are quarantines and travel restrictions and just involuntary travel. So another meeting was canceled, and we'll keep an eye out for everything.
It's good to keep checking the website. It's very useful information.
Absolutely. So let's get into this episode 61. We'll start off with Dr. Ilana Yurkiewicz. The segment this week in Clinical Correlation deals with something a little bit lighter, which is delivering good news to patients.
Yeah, that's the wonderful thing about our specialty is sometimes, and these days with more and more science and things we can use bench to bedside, we get good news. And I try and be careful, to really say it accurately as I do when there's bad news, so as to not overdo it, but certainly to enjoy with the patient, especially if you've been working with the patient for a long time, the wonderfulness of giving good news and praising the patient for all he or she has been through to get there.
That is Clinical Correlations coming up after our interview. Our interview this week is with another person who is in your neck of the woods, the University of Pennsylvania. We're talking about getting a thorough bleeding history. This is with Dr. Adam Cuker, someone you know.
Yeah, he actually, I made the mistake when I first met him. It's spelled C-U-K-E-R, and he pronounced it Cuker because of its derivation from Europe, and it stands for sugar. It's a shortage of that language. And he's our coagulation expert at Penn. And so we did a wonderful interview on the bleeding patient, and we took two types of patient. The one who was about to have something done, like a surgery, and you want to rule out a bleeding disorder. I gave the example of my daughter, I guess 15 years ago, and she was about to have an appendectomy, and said to the anesthesiologist, I think I bruise easily. And I looked up and I thought, oh my gosh, this is going to obligate a big hematology workup. So he goes through someone who's not bleeding, but you might be about to do a procedure and cutting. How can you rule out to bleed diathesis? So it's really useful. And the flip side is you're asked to see someone. The example we like to give is post-cardiac catheterization. There's been an artery entered in the groin. Sandbag's been on it for 4 hours. Nurse calls you, still bleeding. How do you rule out it's a stitch you need versus a hematology consult you need? So he really decoded this very nicely.
And of course, there are robust show notes available wherever notes can be found in your app. And Dr. Henry, I think this is just more proof that whenever we do interviews in person, they seem to go really well. I really like this one just because it mentions in the notes, in our key takeaways section or the practice points, the thorough blood history and take the history from head to toe. And I guess it's just something very basic, but it goes into more detail as to why you do that, like you said. And I thought it was just a plethora of information for various levels.
As useful, if not more so, than the blood tests. And as you mentioned, on our mdh.com/hematology-oncology website, we have show notes. We have 4 wonderful residents at Pennsylvania Hospital. One of them is doing the show notes this week. Do you know who it is, Nick?
Actually, I'm looking through it and I don't. I think it might have Mary Ellen might have helped out because it's usually available in there. But I will edit that part in.
Okay. So we give a shout out to our resident who's doing the show notes, and I think you'll really enjoy this interview on the bleeding patient, about to bleed, or how to rule out bleeding disorder.
Coming up next, Dr. David Henry, Dr. Adam Cuker. This is Blood and Cancer from MD Edge.
Welcome to this podcast. I'm your host, Dr. David Henry. This is the podcast Blood and Cancer, which airs every Thursday morning, and we are delighted you're listening. You can also find us on our electronic journal called mdedge.com/hematology-oncology or mdedge.com/podcast. We're an all-electronic journal of WebMD and Medscape. And today's episode is entitled Coagulation Issues, and I'm delighted to have one of our local experts, Dr. Adam Cuker, who is at the University of Pennsylvania, where he is a associate professor of medicine, and he is director of the Hemophilia and Thrombosis Center. Adam, welcome to the program.
Thank you, David. Nice to be on.
Well, we're delighted to have you, and I want to mention, because many of our listeners may say, who's that guy? I want to ask him some more questions. So while it's pronounced Cuker, it is spelled C-U-K-E-R, and I think you told me that may derive from the word sugar.
Yes, same root as sucrose.
Ah, got it. Easy to remember. Well, as practitioners in hematology and oncology, bleeding issues come up, and I thought we might handle today as two cases I love to teach with. One actually involves my daughter many years ago, when she was complaining to me of right lower quadrant pain and a fever, and I looked at my watch and I said to myself, midnight, and I was off by 5 minutes when her appendix came out as we sat in the emergency room then at Children's Hospital in Philadelphia, and sitting quietly reading my journals and hoping she'd have her appendix out soon, various consultations came by and anesthesia walked in, asked her a few questions, and one was, do you bruise easily? Before I could say to her, oh, say no, she said, I think I do. And so a hematology consult came, and how will you then discuss and advise us on someone who's not bleeding at the moment, is about to have a surgery, like an appendectomy, and says, I bruise easily? How would you approach that patient?
Yeah, thanks, David. And this comes up quite a bit. And this case is a particularly tricky one because most of the referrals I get to my clinic for sort of question bleeding disorder, we have the luxury of time, but your daughter needed her appendix taken out urgently, and so the doctors didn't have time to do a prolonged evaluation.
Right.
So the one thing, the most important step, in my opinion, and the one thing you can do, even in an urgent situation, is take a very careful bleeding history. And I think there's a real art to this. I always ask patients about any history of spontaneous bleeding. So your daughter might have reported a history of easy bruising, maybe in the absence of significant trauma. We always ask about epistaxis, gingival bleeding, rectal bleeding, heavy menstrual periods, et cetera, going right down the body from head to toe. It's also really important to ask about hemostatic challenges. Has the patient had any surgeries? If it's a woman, has the woman had any pregnancies and deliveries? Very important to ask about these questions and whether the patient experienced abnormal bleeding with those challenges. And
I always ask about tooth extraction. Is that a good one? I always ask about how did that go?
That's an excellent one, and that's just what I was going to say. Is there are some sorts of surgeries that you and I think of, but the patient may not think of. So I always ask about tooth extractions. I always ask the patient if they still have their tonsils. I always ask the patient if they've had polyps removed from their colon, because these can be significant hemostatic challenges that people don't always think to report. And then the last thing I try to establish when I take a bleeding history is the time course. Is this a patient who's had abnormal bleeding their entire life, or is this abnormal bleeding that started later in life? Helps us think about whether we're dealing with perhaps a congenital bleeding disorder versus an acquired condition. So that's the most important part of the history. But of course, I also ask about comorbidities that could be associated with increased bleeding risk, like liver disease and kidney disease. It's really important to know what medications the patient is on. The obvious culprits are anticoagulants and antiplatelet drugs. But sometimes patients, I think particularly those with mild bleeding disorders, can have bleeding symptoms with other medications that we don't typically think of as causing bleeding. And those can be medications like fish oil and even SSRIs. So I make sure to take a thorough medication list. Of course, it's really important to ask about family history. Is there any history of a family member who has a diagnosed bleeding disorder, or even a family member who has a history of abnormal bleeding? I also ask about the social history. Is the patient engaged in any activities that would be associated with an increased risk of trauma? As a quick aside, David, I once saw a patient who came to me with new onset easy bruising, and the social history cracked the case when we found out that the patient had recently started boxing. And so we were able to spare that patient an expensive hemostatic laboratory evaluation.
Sure, yeah.
So that's the history is just critical, and those are the components of the history that I focus on.
So now what do you say, of course, back to the case, dutifully they do a pro-time, PT, PTT, although you have to mention to me somehow what happened to the PTT. It's just gone. We all do PT and INR. So she had a PT, PTT, play the count, and you also have to tell me what happened to the bleeding time. I used to love that IV bleeding time. So these tests, they actually did the PT, PTT, play the count, and no bleeding time. And she's good to go, couldn't possibly bleed. True or false?
False.
Yeah. Yeah.
Yeah. So I do, yep, go ahead, I'm sorry.
Well, I was going to say, as you'll probably answer, what are we possibly missing? I like to say, the clotting times, clotting factors are said to be normal 100%, maybe plus or minus 40%, but your PT and PTT run normal when? You can have low percent and still run a normal, true?
That's true, yes. Although I think in general, the PT and PTT, when normal, are pretty good at ruling out clinically significant factor deficiencies.
Okay.
But there are other bleeding disorders that a patient can have in the face of a normal basic lab evaluation. And, just my basic lab evaluation is basically just what you mentioned, a CBC, a PT and PTT. I always do a comprehensive metabolic panel too to make sure the patient doesn't have liver disease or kidney disease that I don't know about. You mentioned the bleeding time, David.
Yes. Where'd it go?
So maybe I'm too new to practice. I have never ordered a bleeding time in my life. But I know that it was a popular test a number of years ago. You may have heard about the Choosing Wisely campaign that a number of professional medical societies participated in. So a few years ago, the American Society for Clinical Pathology, one of their Choosing Wisely items was do not order a bleeding time. And the reason for that, they claimed, was, well, first, it does leave a permanent scar on the patient. It's a fairly barbaric test. But secondly, there really isn't any evidence linking bleeding time results with risk of bleeding. That isn't to say that it might not have come in handy at times in the past, but the evidence to support its use isn't very good, and it is subject to pretty substantial inter-operator variability. So technician A may get a very different result than technician B. So the bleeding time has fallen out of favor, and I think in many health systems, including ours, we really can't order it anymore. In any case, you were asking about if the basic laboratory evaluation, the platelet count, the coags are all normal, can the patient still have a bleeding disorder? And the answer is yes. There are bleeding disorders that can be seen in the face of the normal basic evaluation. And the most common are von Willebrand disease, which may or may not be associated with a prolonged PTT, a platelet function disorder. Other less common conditions would be rare disorders of fibrinolysis, like factor 13 deficiency, alpha-2 antiplasmin deficiency, plasminogen activator inhibitor 1 deficiency. It's also important to think about blood vessel disorders that lead to abnormal bleeding. And so these could be conditions like HHT, hereditary hemorrhagic telangiectasia. So very important to look for telangiectasias on the physical exam. Other blood vessel disorders like amyloid angiopathy or Ehlers-Danlos, all things to consider in a patient who has abnormal bleeding and a normal laboratory evaluation.
I'm so glad you mentioned Ehlers-Danlos. I actually saw a patient yesterday with, quote, ITP, which I think is real, who also is proven by a genetic visit to Penn, Ehlers-Danlos, and she's thinking of in vitro fertilization and procedures and clotting and bleeding, and she had significant bleeding, blood transfusion bleeding, with 3 vaginal births. And so I guess that is a vascular anomaly in her case, and related to the platelets, or is that a separate issue?
Yeah, it's probably a separate issue that has to do with the strength or the fragility of the wall of the blood vessel, the integument. That's very interesting.
Yeah, and so before we leave this patient and go to the bleeder, what happened in clinical practice with PTT? The surgeons now put people to sleep routinely with PTINR, and they'll miss up that pathway 8, 9, 11, so von Willebrand's, hemophilias, and 11 being autosomal recessive, if I remember correctly. Where did it go?
Yeah, so I think that, there is evidence that suggests doing routine coags, particularly APTTs, in patients who do not have a history of abnormal bleeding as part of the pre-op workup is not that helpful, because it's very rare that you pick up a clinically important coagulopathy. And most of the time when you get an abnormal PTT, it's due to something else, like a lupus anticoagulant, a deficiency of a contact factor like factor 12, something that isn't associated with an increased bleeding risk. And so that has fallen out of favor. But the story with your daughter is a little different, because she reported a history that maybe the clinicians were worried was consistent with abnormal bleeding. And I think in patients with abnormal bleeding, they should certainly have a PT and a PTT as part of their workup. All
right. Well, happy to report that the appendix came out nicely and no drama, no bleeding. So then,
that's good. That's good. And actually, David, if I may, it brings up an important point. And one of the challenges of taking a bleeding history is that some bleeding symptoms are very common in the normal population. So a surprisingly high percentage of people who don't have a bleeding disorder report easy bruising, report frequent nosebleeds when they were a kid, report heavy menstrual bleeding. These are very, very common symptoms in the general population, and sometimes it can be hard to use that history to distinguish sort of normal variation from somebody with a true bleeding disorder.
And that reminds me to ask you, I've seen you lecture, of course, educational sessions at ASH and the ASH Update series that goes around the country afterwards, and I think there is a website or something I could put in our show notes where it gives this special bullet points of bleeding history that one might take to kind of be more or less comfortable that there actually is a bleeding disorder.
Yeah, I think what you may be referring to is a bleeding score.
Yes.
There are several different bleeding scores that have been published. I think probably the best known one is called the ISTH-BAT, which stands for International Society on Thrombosis and Hemostasis Bleeding Assessment Tool. It's a pretty cumbersome tool. There are a number of criteria that you have to ask the patient about, and it can take, I think, probably a good 20 minutes or so to complete that assessment. So it's not easy to do in a busy clinic. The other point I'd make is it was primarily developed as a research tool.
Okay.
In my opinion, at least, these bleeding scores haven't been sufficiently compared to sort of a Gestalt bleeding history in clinical practice to replace what we already do. I don't think they've been properly validated to replace the bleeding history in clinical practice. But certainly there's room for that kind of research, and who knows, maybe in a few years we'll be recommending doing bleeding scores in our patients.
Okay. All right, so I wanted to cover the other patient and the one I like to teach is you're called by the nurse who's watching a patient who's been to the cath lab for coronary disease, rule in, rule out, and is back in the room, kind of sleepy, do the Ativan, and she tells you that the sandbag on the right groin is now wetting for 4 hours. And the cardiologist said this was a perfect catheterization and it must be a bleeding disorder. Call hematology, rule out coagulation disorder. How do you approach that patient?
Yeah, this happens not infrequently in the hematology consult service, right? Yeah.
Yes.
So I think that we certainly need to consider the possibility of a bleeding disorder, but also no matter what the surgeon or interventionalist tells us, we also need to consider the possibility that this is just an unligated blood vessel, a blood vessel that needs to be cauterized.
Absolutely.
As a complication of the procedure itself. So these are the sorts of patients where, once again, an efficient but thorough bleeding history is really important. Is this somebody who has had many hemostatic challenges in the past without abnormal bleeding? If so, that's going to make me think this could be a surgical complication rather than an underlying bleeding disorder. I also would do, in the appropriate circumstances, a basic laboratory workup to make sure that the CBC the platelet count is okay, that the PT and PTT are okay. I would review the patient's medications. In a situation like that, the patient could very well be on heavy-duty antiplatelet medications after a percutaneous coronary intervention, and those could certainly contribute to bleeding. So I would actually use very much the same approach in somebody like that with active bleeding as I would in somebody who's not bleeding, only with, of course, more urgency. And I would be doing that evaluation in parallel with at least local measures to try to get the bleeding to stop, like applying heavy pressure.
Would you say here in a patient like this who's now bleeding, and we could use a post-op surgery or another case of a delivery of a baby or a hysterectomy, that you're quickly trying to determine a stitch or no stitch coagulopathy? Now the PT-PTT platelet count might be more useful in giving you comfort this is not, because some factor deficiency would have shown itself by now.
Yes, agreed. I mean, I think a platelet count and a PTT, you get those results back in 20, 30 minutes, and that's a very rapid way of ruling out a large number of different bleeding disorders. As I noted before, there are some bleeding disorders that could still be present even in the face of those labs being normal. But yes, it's an efficient way to rule out a number of possible conditions, including some really important ones like a rare acquired factor VIII inhibitor, which can occasionally occur in hospitalized patients, and very, very important to diagnose quickly so that appropriate treatment can be started.
Okay, great. So my takeaway from that is a quick evaluation. Do we need a stitch? Whatever the surgery is, this case being the cardiac cath or coagulopathy, review the history, watch for those medications, and quick get your labs. I think that covers our two patients very well, but I didn't want to end without bringing up what's on everyone's mind lately. It used to be called NOACs, but that got so boring because they weren't new anymore. They were called DOACs, the direct oral acting anticoagulants. And if I mention the two that we seem to use a lot in hematology and oncology, the rivaroxaban and the apixaban, and of course the acute presentation of bleeding and whether or not we use these antibodies to reverse. So I guess the case I'm thinking of, one happened recently at our hospital, a patient's last apixaban dose was 8+ hours ago in the emergency room with an intracerebral bleed. What use is a PT or PTT to see if any drug is present, and or when might you pull the trigger on giving the antibody to reverse the drug?
Sure, yeah. So the PT and PTT are unfortunately quite insensitive to apixaban, as well as to the other DOACs, but apixaban in particular. And so I would order a PT and PTT in all of those situations where I had a patient on a DOAC who was bleeding. If the PT or PTT were prolonged, that could very well suggest that there are substantial levels of drug in circulation. But if they are normal, that does not rule out the possibility that there are clinically meaningful levels of drug in circulation that are contributing to bleeding.
Oh, that's really helpful. Okay.
Yeah. So, I mean, if you are in an institution where you have the ability to get a rapid anti-10A level back, that can give you much more specific information on whether there are clinically significant levels of rivaroxaban or apixaban on board.
Okay.
But many of us don't have access to that test, at least not on a stat basis. And in a situation like that, where I don't have access to the definitive laboratory testing, if the patient's having a very serious life-threatening bleed, like an intracranial bleed, I personally would err on the side of giving the medication.
Give the drug.
In this case, the reversal, the FDA-approved reversal agent for rivaroxaban and apixaban is a drug called andexanet alpha. Yeah.
And actually in that case we did give it, and sadly the hemorrhage progressed and the patient died. But certainly a patient that we're all going to see and go through this thought process would be very useful. Well, I think we've taken up enough of your time, and I've certainly learned a lot on the rule-out bleeder, the one who is bleeding, and watching out for those DOACs who come into your clinic or emergency room. Adam, I want to thank you very much and remind everyone that we've been speaking with Dr. Adam Cuker, who's Associate Professor of Medicine at the University of Pennsylvania, so-called Hospital University of Pennsylvania here in Philadelphia, where he is the Director of the Hemophilia and Thrombosis Program. And Adam, thank you very much for being with us.
Oh, it's been a lot of fun, David. Thanks for having me on.
You're very welcome. And for those listening, the show notes will be posted in bullet format online at mdh.com/hematology-oncology or mdh.com/podcasts. And we all thank you for listening. Thanks, Adam.
And that concludes the interview portion of our show this week. Don't forget, if you enjoyed the interview and want to learn more, you can learn more about our guest and any of the topics discussed by checking out the podcast show notes, which are available wherever notes are found in your app. When we come back, it's time for Clinical Correlation. Welcome back to Blood and Cancer, the official podcast of MDH Hematology Oncology. It's time now for Clinical Correlation with Dr. Ilana Yurkiewicz.
I'm Dr. Ilana Yurkiewicz, and this is Clinical Correlation, a segment about the human side of hematology and oncology care. In our field, we are known for giving bad news. As such, we have training sessions for incoming fellows and more experienced hematologists and oncologists on how to deliver bad news. These are extremely helpful, and so is just doing it in a variety of situations with different types of people. We don't get training in how to give good news. This is, of course, understandable and defensible. We train in difficult skills. How difficult could giving good news possibly be? My thoughts were tested recently when I was seeing a patient for follow-up. He had AML with good risk genetic features, and after one cycle of decitabine and venetoclax, his bone marrow biopsy showed remission. He had less than 5% blasts and was negative for minimal residual disease. I was ecstatic when I pulled up these results before seeing him myself for his appointment. As I usually do as a way of easing into serious conversation, we chatted about other things first. I asked how he was feeling on the therapy, side effects, energy levels, appetite, etc. Then, without preamble or introduction, I just said it. "Your bone marrow biopsy looked great," I said. He looked shocked, genuinely shocked. "What does that mean?" he said, and I explained. It was a really emotional moment, and I was grateful to be part of it. He started to cry. His wife asked if she could hug me, even though I didn't feel like I could take any credit for what the therapy had achieved. "Wow," he said, "I wasn't expecting you to just come out and say it like that." And so it made me think. When I give bad news, I usually give a warning shot. I say something like, "We have some serious things to talk about today." When I gave this good news, I just gave it. I have no idea if this was the best way to go about it. Because the thing about good news is, when the content is good, I think people usually do pay less attention and are less impacted by everything else like tone and body language. But since there are no standard ways or training to go about this, I wonder how other people do it. Feel free to reach out to me or our podcast if you have a strategy you really like. And regardless of strategy, I hope we all have the opportunity to give and share in as much good news as we can. Thanks for listening, and I hope you'll tune in next time for Clinical Correlation.
And that's a wrap on episode 61 of Blood and Cancer. Let's get to this week's credits. Blood and Cancer is produced and hosted by the editor-in-chief of MD Edge Hematology Oncology, Dr. David Henry. The clinical correlation segment is written, recorded, and produced by Dr. Ilana Yurkiewicz. Blood and Cancer is produced by Mary Ellen Schneider. All of our podcasts at MD Edge are produced by our executive editor, Dr. Ivan Aransky, along with executive editor Mary Ellen Schneider and Kathy Skarbeck, and multimedia editor Terry Rudd. Social media is produced by Kyla Clark. I'm the voice of MD Edge Podcasts, Nick Andrews.